I'm trying to keep it simple just so that the terms that you see in histories or pathology reports or random tests that get faxed to you because you've seen the patient before, to help put those into a better framework. And it's clearly a big topic because everybody's talked about it. And so I'm going to go very quickly through just the highlights. So the point of what we do when we look for molecular markers in tumors is that we take people, a bunch of different people with the same tumor, and we try to use the information that we can to classify them either prognostically into good prognosis versus poorer prognosis, or in terms of will they respond to a particular chemotherapy or not, which is classifying them predictively. The way that we classify tumors is you'll see on path reports the T stage, N stage, and M stage, and that's pretty much the T stage is the depth of invasion, N stage is whether or not it's metastasized to lymph nodes, and M stage is whether or not it's metastasized farther away. You can also classify tumors by morphology, so do they look like, are they well differentiated or poor differentiated cell of origin? Are they from the glandular epithelial cells or maybe neuroendocrine cells? And then molecular pathways, which we're going to talk about. And then kind of a newer thing that everybody's touched on a little bit is related to the immuno score, which is trying to grade the body's immune response to the tumor and how it's reacting to it. So because I'm a pathologist, I see the specimens taken out of people. And this is the colon, which has been, it's like a tube. We open it lengthwise, and then you can see the tumor in the middle. All of this is what normal colon looks like. And again, what we're looking for when we get the specimen is how far the tumor has invaded through the bowel, from the inside through the bowel wall, and whether or not it's involving lymph nodes or other tissue. Again, we look at predictive versus prognostic markers. Predictive markers are KRAS and NRAS, which are these EGFR and RAS pathways that we've talked about. HER2 immune checkpoint inhibitors like PD-L1, MMR, which is also predictive because it predicts response to checkpoint inhibitors. Prognostic, BRAF is prognostic and somewhat predictive too, and MMR, which is mismatch repair again. And these markers they relate to a lot of different tumors, but they're most established for like HER2 related to gastroesophageal carcinoma, and then mismatch repair, which again is associated with a lot of different tumors, anti-EGFR, BRAF, and PD-L1. And again, PD-L1, a lot of different tumors. But in this context, we're going to talk about them with colorectal adenocarcinoma. So starting at the top of the GI tract, which is, for this talk, the gastroesophageal, the junction between the esophagus and the stomach. One of the markers that we use is HER2, and that's to predict response to treatment to trastuzumab or Herceptin. And what we're looking for is increased expression of HER2 on the tumor cells, which is increased expression is associated with about 20% of all gastric and gastroesophageal adenocarcinomas. The people that are tested are essentially all patients, but it's particularly important for patients who are unresectable, metastatic, or recurrent cancer. And the importance is that it has an increased overall survival when combined with chemo versus chemo alone. This is just a algorithm to show that we test patients who could potentially be helped by HER2 therapy. And then so we test the biopsy specimen. If it's negative, then it's negative, and the patient will not benefit with Herceptin. But if we get the resection tumor, then we can test that again because the expression isn't uniform throughout the tumor. The other options are equivocal by immunostaining, which is the brown staining that you'll see. And if it's equivocal, then we go to a different test called FISH. If it's negative, then it's just negative. Gastroesophageal tumors that are more likely to be HER2 positive are tumors at the GE junction, those with intestinal morphology, and those that are better differentiated. Tumors that are less likely to be HER2 positive are those that are in the stomach, that have diffuse or signet ring morphology, and that are poorly differentiated. And here is what normal stomach glands look like. This is a moderately differentiated intestinal type of adenocarcinoma, and you can see that Here the nuclei are small and they're basally oriented along the edge of the glands. Here the nuclei are much larger, they've lost polarity, but they still kind of show like the same glandular architecture. And then this is poorly differentiated with signet ring cells. The way that we grade HER2 is that we start by looking at an immuno stain, which is a brown stain that reacts with specific proteins either within the cell or on the cell surface. And the options are is that it's negative, weakly positive, which we interpret as negative, and then you can get, it's called incomplete membranous staining, which is equivocal, or diffuse strong membranous staining, which is positive. If it's equivocal, we reflex to FISH, which is a different type of test that uses chromogens that attach. There's one that attaches to the centromere of every chromosome, and that's the green one. And then there's the one that specifically looks for HER2, and we're looking for increased expression. So it's positive if there's increased orange or red staining relative to the green. Normal cells would just have 1-to-1 ratio. So moving along to colorectal cancers, like we've heard before, mismatch repair is, and I promise that Dr. Hecht and I have not collaborated before, but we have a lot of the same analogies. So mismatch repair is the proofreading component of DNA. So when cells replicate, they have these proteins that go along to make sure that it was replicated faithfully and that there's no errors in spell check. So it's kind of like this spell check of the cell. It's associated with sporadic mutations, which happen in tumor cells, versus germline, which is associated with Lynch syndrome, which we talked about before. And then this is what a colon adenocarcinoma looks like. So this is the normal colon. And again, you see these well-spaced, kind of uniform-looking glands with the nuclei are basally oriented along the edge of the gland. And then up here is the tumor, and you see that it's more disorganized architecture, the nuclei are bigger, there's loss of polarity. When we stain for MMR, we're looking for intact proteins. And the intact proteins stain, so in the normal, they stain the nuclei, and in the lymphocytes, because they're in all, mismatch repair is part of all cells. In the tumor, there's no staining, so the nuclei just look blue. And here's a higher power picture. Who's tested? Essentially all new patients with colorectal cancer are tested for mismatch repair. If you have loss of MLH1 and PMS2, which are the most common proteins that are lost, that are aberrant, then we test for BRAF mutation and hypermethylation, because if you have mutations of those, then it's more likely associated with a somatic mutation. If these are negative, then we test for, then you follow up with genetic testing for Lynch syndrome. And if you've lost any of the other 3 proteins or combination of those proteins, then you automatically, the next step is to test for Lynch syndrome, because these are more commonly associated with germline mutations. So as you've heard, patients with MMR have decreased recurrence rate, longer time to recurrence, and better overall survival. So they have a better prognosis. And they do respond better to immune inhibitor checkpoint therapy, and then there's a little bit of controversy about the predictive response to other chemotherapeutic agents. So the way that this works, so in terms of immune checkpoint inhibitor, which is PD-L1, which Keytruda, Opdivo, the things that you've heard about on the news, not on the news, in commercials, this is how we determine if we think the tumor is going to respond to these drugs. And it grades the patient's immune response to the tumor cells, so how well the patient's immune system reacts to the tumor. And if the patient's immune system reacts strongly to the tumor, they have a better response to PD-L1 inhibitors. So patients who are tested, patients who are high, so who have increased mismatched repair defects, and patients with metastatic or refractory disease. And it's kind of turning into a little bit of everybody, or whenever we're asked by the oncologists, because they are trying to figure out the best treatment for patients. And again, this is, so the way that immune checkpoint inhibitors, or the way that immune modulation works is that the tumor cells die. Some of these scavenger immune cells say, these guys, they're not right. They don't belong here. They pick up some antigens. They show them to the T cells. The T cells say, you're right. Those cells do not belong here. Let's get them out of here. And that's how your immune system responds to the tumor cells. And again, the T cells, the COP analogy, so the T cells go up to the tumor cell and they say, you don't belong here. And the tumor cells say, no, here's the PD-L1 receptor is like, oh no, here's our ID. And the T cell's like, okay, see you later. So the point of PD-L1 inhibitors is to, it's like the UV light on the ID to say, that's not a real ID, you guys gotta get out of here. The way that we grade the immuno score, which is, again, this is kind of more towards the future. But so we look at our regular H&E stain, then we stain it for PD-L1. Are the lymphocytes expressing PD-L1? And we look at the invasive tumor front, so where the tumor is trying to invade, are they trying to bypass and show their ID? And so the brown stain says, yes, there are T cells checking IDs. And then the CD8 looks for activated T cells, and we look for activated T cells along the invasive tumor front as well as within the tumor. So is there actually an immune response to the tumor? Okay, good, PD-L1, we've heard about it. Next. Another predictive marker in colorectal chemotherapy is anti-EGFR therapy, and this includes cetuximab and panitumumab. And again, patients that are most frequently tested are those with unresectable disease, recurrent or metastatic disease. And then when we test for these predictive markers, we would prefer to test metastatic tumor or recurrent tumor over the primary tumor. And so the way that these work is that EGFR is expressed on the surface of the cell. And when EGFR is activated or overexpressed, it essentially tells the tumor cells, it's party time, guys, start replicating. So one tumor cell goes to many tumor cells and the tumor proliferates. The frequency of EGFR mutations or increased expression is about 50 to 90%. And then it activates these downstream pathways to tell the cells to proliferate. So if you're blocking if you turn it off, it's like turning off the music to the party, telling everybody to go home. But if you have mutations in the RAS pathway, and specifically KRAS and NRAS, exons 2, 3, and 4, then it's like these guys have their own headphones, and they're like, party's not over, we got our own music, guys. And they keep replicating, and the tumor proliferates. And these are frequency is about 40% for these mutations in colorectal cancer. Another marker along this pathway is BRAF, and it's prognostic in that it's associated with a worse prognosis if this mutation is present in the tumor over colorectal cancers that do not express this mutation. And it may suggest a need for more aggressive chemotherapy. So again, it's along this pathway, and if there's a mutation, the frequency of this mutation is about 10 to 15%. Okay, so I guess we're going to take questions at the end, but that's it.